Good afternoon, welcome, and of course, thank you for joining. First, I wanted to acknowledge Terry and Kelly Hernandez, who have been orchestrating this series of webinars and seminars in the medical care aspects of children with trisomy 13 and 18. So again, Terry and Kelly, thank you for your great efforts and your skills. So it's a pleasure for me to introduce our speakers this afternoon. Dr. Burge, the first of our two speakers, is an assistant professor of pediatrics at the University of Nebraska and the medical director of the newborn intensive care unit at the Children's Hospital there in Omaha. After she speaks, Dr. Megan Weaver, who's also an assistant professor, will speak. And I will turn the virtual microphone over to Dr. Burge.
Thank you very much, Dr. Terry. It's a pleasure to share with everyone today some of the experiences we've had in Omaha caring for children with trisomy 13 and 18. During our talk today, we're going to kind of break it up into two separate portions. I'm going to talk a little bit about surgical interventions, both cardiac and non-cardiac, on a cohort of patients who have had trisomy 13 and 18 that we've cared for in Omaha. And then Dr. Weaver is going to review parental perspectives of quality of life and functional status of a cohort of these patients who have undergone surgical intervention. So some of the background in terms of how Omaha got to where we are in caring for this cohort of patients. Up until 2017, surgical intervention was offered mostly to local families who requested or preferred that degree of intervention. A lot of our local families chose palliative care or non-intervention, and so it was a small group of children who were undergoing cardiac surgery. But the impetus really started to change in that year as more local families requested to have surgery on their babies for cardiac repair. And our CT surgeon, Dr. Hamill, who I've listed here, was able to review some data, and he once told me he compared the surgical outcomes of babies with trisomy to heart transplant and saw that they were very similar. And he said, well, if we're offering heart transplants to patients, so why aren't we doing more cardiac repairs for patients with trisomy? And he was able to present some of that data at a SOFT conference. Shortly thereafter, the number of referrals we started getting from both local families as well as families from outside of the Omaha area really increased, to the point where we had to develop a more formalized process to make sure that the right patients were coming to our facility so that we could offer intervention for the patients where it was most appropriate. And in some cases, we did at one point offer local delivery in Omaha if that was feasible. So there were a couple of ways at which referrals came to us. One of those was postnatal, so families delivered at their local hospitals and then reached out to our team, where we were able to review echo images and other studies like MRIs and that sort of thing. This data was reviewed with a what we called a trisomy team, which is a multidisciplinary team that consisted of the providers listed there. Most of these babies had general pediatric surgery problems as well, and so our general pediatric surgeons were often involved in those reviews as well. And so if we thought patients needed intervention that we could provide at Omaha, then we would set up the process for getting them here. We also had a subset of patients who came to us before delivery with in utero diagnosis of trisomy and findings on fetal echo that were concerning for some type of congenital heart disease. And so some of those mothers were actually able to come to Omaha, where we could get images here, we could perform fetal MRI studies, and then meet with our local obstetrics team as well as with our other neonatal and pediatric specialists to review the data that we had gathered from their visit to Omaha. And in some cases, those mothers were actually able to relocate to Omaha for delivery of their babies. However, we've kind of reverted back to our previous process where we're encouraging families to deliver locally where they live and then undergo a postnatal transfer after delivery has been done. So since this started in 2017, we've had contact with about 170 families or physicians who have reached out to our institution looking to see if maybe we could help in caring for their babies with trisomy 13 or 18. So far, 44 families or patients have come to Omaha for cardiac evaluation. 34 of those have undergone some type of cardiac intervention, and I'm going to review a little bit about the types of surgeries we've done, both cardiac and non-cardiac, and then of that group, Dr. Weaver was able to interview 10 of those families, and so she's going to talk about their experiences and how they perceive the quality of life of their babies after a cardiac intervention. So this graph just depicts the number of cardiac surgeries or procedures we have done. And in the early years, you can see it was just a handful, and in some years, we weren't doing hardly anything. And then things really skyrocketed between 2017 and 2019. We had to slow down significantly once COVID hit this year, and so that's really slowed down a lot of our elective surgeries and that sort of thing. So we'll see how things go for the rest of the year, but clearly in 2019 was our busiest year, and we did a lot of surgical procedures that year. Not surprisingly, the most common cardiac diagnoses we see is a VSD, just because that's a common cardiac defect to have. That plus aortic arch obstruction or double outlet right ventricle were the most common types of repairs that we did within our institution. Some babies who were referred here ended up not getting repair for a variety of reasons, and so that's indicated by the blue bars. And then we had a couple of babies who had some more unusual anatomy, like a PA window or a vascular sling. If we look at all of the babies who came here for cardiac repair, we can see some trends. Those babies were small when they were born with a median birth weight of 2 kilos. An overwhelming majority were female. They were typically born a few weeks early at 37 weeks, although we did have some preterm infants as young as 32 weeks who were delivered and transferred for care. There seemed to be a trend toward delivery by cesarean section, and that was for a variety of reasons, some of which because the baby was breech and couldn't be delivered vaginally, and another significant proportion was due to fetal intolerance of labor. The babies all had intrauterine growth restriction, but between the time that they were born and the time they had their first surgery, their weight had increased significantly from 2 kilos at birth to a little over 3 kilos at the time of surgery. And most of these babies were getting surgery performed within the first 2 months of life or less than 2 months of life. Although you can see our range has varied significantly. Some babies as young as 6 days, and some babies were a couple of years old before their first cardiac surgery. In terms of non-cardiac surgeries, we've also done a variety of interventions. The most common has been a G-tube placement, and we have received patients from other hospitals where a gastrostomy tube was placed prior to transfer. We've done a fair number of tracheostomies as well, and then kind of a little bit, a smattering of other general surgery procedures that you can see there. We had started to see an interesting trend for babies who developed necrotizing enterocolitis during our last year and a half, and several of those had to undergo an exploratory laparotomy for neck, and a couple of them actually lost a significant amount of bowel and ended up with short bowel syndrome. We also had a couple of babies who had myelomeningocele repair, as well as 2 who underwent hepatoblastoma resection. Several of the babies underwent a change in their need for respiratory support before and after cardiac surgery. We tend to think that if we can fix the cardiac defect, then we may be able to wean these babies off respiratory support. And so in this slide here, I've just kind of compared their respiratory support before and after cardiac surgery to give everyone a sense for how often we were able to make that happen. And what we saw that we were discharging more babies home on oxygen after cardiac repair. Some babies were able, however, to still go home without any respiratory support in room air, but a fair number still required a tracheostomy with ventilator support after cardiac surgery. And then everybody who was here went home with some sort of feeding tube, whether that was a G tube or a nasogastric tube for feeding. There have been some other interesting observed patterns that we have noted here that haven't been very well described in the literature to date, and so I wanted to review those very quickly, and I've listed the top 3 so far. Pulmonary hypertension, I don't think has been very well assessed in babies who have trisomy 13 or 18, and we started to notice in the first couple of patients that we repaired that they had a surprising degree of pulmonary hypertension, and we started assessing their hemodynamics around the time of surgery to try to figure out if this was an issue that would be alleviated with repair of their cardiac defect. So we had 26 patients who actually underwent heart catheterization to assess their hemodynamics. And of those 26, 24 eventually had cardiac surgery. 2 had significantly elevated pulmonary vascular resistance that we thought made it unsafe for them to undergo cardiac intervention, and we thought that the risk was too high. And so that was a little bit surprising to us as well, because in those 2 babies, their PVR changed very significantly and very rapidly between the time that we did our initial evaluation and then the time they made it to Omaha. So of those 24 babies who had heart surgery, about 80% had evidence of pulmonary hypertension before heart surgery, but still about 60% had pulmonary hypertension after heart surgery. So what we were noticing was that despite correction of their cardiac lesion, there was still a significant proportion who still had some evidence of PH despite cardiac repair. So as we tried to learn more about why that would be, we decided to divide these 2 the 2 groups into groups based on the type of shunt that they had. The first group that I have listed here was the majority of babies who had some sort of left to right shunt with unrestricted pulmonary blood flow. And we had 20 babies who met that criteria. And then the second group had right to left shunting with restricted pulmonary blood flow. And there were 4 babies in that category. And then we compared the pH therapies that we used in those 2 groups before and after cardiac intervention. And you can see that despite surgery, a fair number of babies, regardless of what group they were in, still required some sort of treatment for pulmonary hypertension, even after cardiac repair, including we transitioned to discharging babies on targeted pulmonary hypertension therapy, most commonly sildenafil, after cardiac surgery, but we still had a fair number that required some sort of invasive ventilation via tracheostomy and a mechanical ventilator even after cardiac repair. So I think there's still a lot we don't know about why babies with trisomy have what appears to be a more reactive pulmonary vascular bed, but this is an interesting trend that we had not noted before, and so we're trying to figure out now why that would be, and can we do things that might augment this, including operating even earlier on some of these babies. We still do the standard treatment for babies who have pulmonary hypertension, so as I listed before, oxygen, good ventilation, targeted therapies, and then other things that will minimize ongoing insult to the lungs. Most of them now are getting assessed for sleep apnea, including sleep studies, and then of course making sure that they have adequate growth. The second surprise correlation we found was that of osteopenia and fractures in this cohort of patients that we had. And this was prompted by one of our patients who just had an incidental fracture noted on x-ray, but there was no known trauma. The baby had been hospitalized the whole time, so we couldn't really figure out why this baby had a fracture. And so we went back and did a chart review, and at that time we had 29 patients who we were able to analyze, and fractures were found in 45% of those patients. The clavicle and the ribs were most commonly affected, but there was one with a humerus fracture. And 6 out of the 13 children who did have fractures had a fracture in more than one location. And so this was an unusual finding, something that had not been described before in the literature. And we were able to publish some of our data that was just accepted earlier this month in the American Journal of Medical Genetics. And so that is available for review if anyone is interested. We've also noted, even when fractures weren't present, that there was osteopenia in a significant proportion of our infants. And so when we went back and looked at their charts, the things that you would commonly associate for developing osteopenia, like low birth weight or prolonged TPN use, steroids or diuretics, were not present in those babies. And so that prompted us to change the way that we approach screening and management of osteopenia. We have early consultation with our dietitians. We trend calcium and phosphorus levels, and we monitor alk phos levels, and we supplement them with vitamin D, calcium, and phos as needed in order to prevent the development of osteopenia and fractures in that patient population. The one other thing that we're just starting to look at is the association of cleft lip and palate in babies that eventually require tracheostomy. And this, again, was something that we hadn't really seen a significant trend on with some of the babies that we cared for earlier at our institution. But as the cohort began to grow, we realized that those who had a cleft lip and palate were at higher risk of requiring a tracheostomy. And so we had 5 babies with that craniofacial issue that ended up requiring a tracheostomy. And when we look back and compared it to those who didn't have a cleft lip and palate but still had some sort of obstruction, those babies weren't requiring tracheostomy. So we think that there's something about the anatomy of their cleft lip and palate that's causing them to have obstruction that's not necessarily just isolated obstructive sleep apnea. And so we're looking into those charts now to try to figure out what is it about the cleft lip and palate that is putting them at higher risk for tracheostomy. So with that in mind, I'm going to turn it over to Dr. Weaver. She doesn't know I put that picture up there first. Sorry to surprise you in such a way. And I'm going to stop sharing, and we'll allow her to take over so she can talk about the parental perspective.
Thank you, Dr. Burke. Thank you for the presenting. And so I look forward to sharing with you the experience of families. So as a palliative care physician, here in Omaha, I have the privilege of palliative care is an automatic consult for supportive care and communication and goals of care for all of the patients fetally and postnatally with trisomy 13 and 18. So I was quite interested in the family experience, particularly the family's perception of the meaning of the child in the family. It allowed us to place some of the medical interventions and the pursuit of interventions, such as the escalation of technology, into context, what was motivating and inspiring families. So we started out by utilizing validated quality of life scales and then narrative inquiry, just to generate a summary of parental perspectives on quality of life and functional status. Specifically, we published on 10 patients who came from out of state who were denied cardiac surgery in their home state based on genetic diagnosis. So our clinical interest included many more patients, but we published specifically on that cohort of 10. Next slide. The reason this is interesting is because we recognize that cardiac surgical intervention remains somewhat controversial based on geography or based on the beliefs or perceptions of the medical team where the child resides. We also experienced from the wonderful work of Annie Janvier and her team an understanding that many families and parents of children with these diagnoses received very strong language in pregnancy and in delivery, to where it was at times challenging to celebrate the child's arrival into the family because the messaging was lethal, universally incompatible with life. Over half of families heard that their child would be a vegetable. Over a quarter received a very clear message from providers that the child would destroy their family or their co-parenting relationship. Over half had language of meaningless life or even a life of suffering. Next slide, please. And our experience with families was that this wasn't necessarily a universal family experience. So with permission, these are photos of some of the children who received care in Omaha. And we're seeing vibrant children who are celebrated and loved and very much have a place of meaning as a sibling, a grandchild, a community member. So I was interested to explore that concept, what the child meant to and for the family. Next slide. What's very important too is we focus a lot on quality of life, and providers often emphasize that this might be a short life, even with escalation of medical interventions. So in palliative care, we speak of a quality of life. We also speak of a quality of a remembered life. So I was quite interested. It's a small cohort, but a team in Germany actually interviewed bereaved mothers of neonates with trisomy 13 or 18 and asked them in their reflection upon the child's life, their sense of meaning. And the universal language from this qualitative study was positive memories about the infant's quality of life. So even if this was a short life or a life that was not sustained, even with medical interventions, the memories were one of the key words that came out of the interviews were that the child was friendly, engaged, happy, peaceful. Next slide. Something that's also quite interesting is we know that quality of life is a subjective term, and we must be very sensitive that we don't define for someone else what their quality of life is, or for a family, how we should not offer per se families our definition of quality of life, but more explore how the family might define quality of life, especially because we know that providers and parents do differ in definition. So this paper just came out last month in the Journal of Perinatology, and it is not specific to trisomy 13 or 18. It's actually universal across neonatal diagnosis. But I found it really interesting because we recognize NICU physicians and parents do actually put equal weight and value on quality of life as a metric. So we share the value. That said, we actually really define very differently quality of life. So parents tend to accept higher levels of disability, whereas neonatologists are more inclined to accept higher level of technology for a child, so long as the level of disability is not higher. So we must recognize, and I appreciated this paper's quote, we cannot adequately define or standardize the use of quality of life in clinical context. So we can talk together, we can share definitions, but we must maintain that quality of life is a subjective experience and definition. Next slide. So for this particular study that I'm grateful to be able to report on, we interviewed the first 10 parents from out of state for children with diagnosis of trisomy 18 or 13 who came for surgical intervention, who had self-defined that they were, language was not allowed or not able to access in their home setting due to the genetic diagnosis. It was very important. I'm quite interested in paternal inclusion and co-parent perspective. So we really tried to ensure that we included the parental dyad if there was a co-parent relationship. So a total of 14 surveys were completed for 10 children. Next slide. We had a nice diverse range of cardiac conditions, and the age at time of surgery was 2.7 months as a mean age. And then we allowed for a lapse of close to a mean of a year to allow the family to celebrate the child at home, learn more about the child, and explore the child's quality of life based on family experience. Next slide. So I was very interested in utilizing a mixed method approach because we know quality of life is an elusive metric because it is so subjective. So really looking to see if we can triangulate and really look with many lenses on quality of life using qualitative narrative inquiry, which was recorded and transcribed for content. There's validated quality of life ranking scales. There's visual analog scales, which are graphs where you are able to visually depict, not using words, but pointing and gesturing based on validated graphs. And then utilizing validated measures. So the PedsQL parent report, we use the PedsQL family impact module, which helps to measure the family's experience, and then utilized a parent reported functional status scale. Recognizing ahead of time that people might say, well, the family perceives the child as more interactive or more mobile or more verbal or more expressive than the child might appear to a neutral third party. We actually also then utilized a pediatrician to also complete a functional status scale. So a neutral pediatrician in the child's community who was not part of the study completed the scale for comparison. Next slide. So we recognized when asked in phrasing, and there are many different questions that allow us to kind of try to protect against bias, that all parents, 14 out of 14 rated their child's quality of life as high when asked ranges and when asked 10 different ways. And then using visual analog scales in different graphic depictions, the mean response for quality of life was 92.7, so quite high. Next slide. And then the PedsQL scoring, the parents rated the child's quality of life as 80 over 100. And of interest and relevance is that the parents actually rated the child's quality of life as higher than their own quality of life, which is actually very concordant with children with chronic or complex conditions that are dependent on family caregiver for activities of daily living. It's quite common that the parent is actually loving in a sacrificial way. I personally find this interesting, not just from an academic standpoint, but from a humanistic standpoint too. So it's very common in palliative care that parents rate the child's quality of life as higher and actually say that they prefer it that way. You know, that they prefer to lose sleep to know that their child is resting well. You know, they prefer to eat late knowing that they've blended whole foods for their child. And so there's a certain altruism that parents depict almost a pride in interviews. Of a really important interest, I was curious, well, for children who don't have a genetic diagnosis, what is their quality of life rated by family members? And so was only able to find about 3 or 4 studies that used a similar age cohort without genetic diagnosis. And of great interest, the range was about 75 to 85. So we were right in the middle of even children who don't have genetic condition in the background. Next slide. I did explore some correlations because based on the functional status scale, I wondered, if the child is more dependent on caregiver, or if the child is less expressive or interactive, does that correlate with the family's experience, the family impact? And we did find, yes, using Spearman's correlation score, particularly the parent quality of life was impacted, and that measures things like sleep or time for self-care, time for maybe employment outside of the home. So there were some correlations. What I was most interested in exploring were things like family relationships, because as we saw with Annie Janvier's work, providers make a lot of judgment statements to families about the child detracting from family relationships, whereas we were observing in clinical practice that the child seemed to be adding to or strengthening family relationships. And so wanted to explore that further. Next slide. Also of interest, so this is a Bland-Altman plot, and this actually shows the correlation between how neutral third-party pediatricians rated the child's functional status on validated scale and how the parents did. There's one main outlier, so there was one pediatrician who seemed to believe the functional status was quite lower than the family's perspective. But altogether in the gray, you can see correlation, and we see an agreement of 0.89, which is really, to put that in non-numeric terms, the pediatrician's perception of the child's fine motor and gross motor and interactivity was actually very consistent with the parent's perception. So if I were to be like just a little brash and be frank, we can't say, oh, the parents say quality of life is high because they're delusional about what the child does or doesn't do, because actually the parent is assessing the functional status as a neutral third-party pediatrician would do. The reason I chased after that in this particular study was many people would say quality of life is defined by functional status. And as a palliative provider, we're very committed to saying that quality of life might be defined by relationality or purpose, spirituality, connectedness. It doesn't always have to be productivity or cognition. Next slide. So personally, I do tend to lean a bit toward qualitative in where the richness, the data can measure, but the qualitative and the narrative can be just so profound and can speak into the gaps of the data. So there are just two exemplary quotes here. So a mom shared, she's doing things we're told that she would never do. They told us she'd be incompatible with life. She can sit, smile, laugh, and say mom. She rides her horse with a special saddle and support, pets her cats, pets her dogs, loves to play in the water or float and splash. She is the light of our life. She is almost always happy and full of sass. She's the strongest person I know, and I am so proud to be her mom. And so very touching narrative. And this is a mom who sends pictures and videos of the child engaging with her world. Then a paternal quote in green, speaking of his son. He has a high quality of life, and he actually really increased my own quality of life. He really turned my life around. I was not making good decisions for my family and was really focused on myself. His birth and his surviving made me realize about bigger purposes in life. Now I'm a better husband and a better dad. I live for more than myself now. I mean, this little guy really made me a better man. And I will say, I chose that quote because I experienced in many of the interviews, in many of the conversations that we have at the bedside that aren't research conversations, that are just bedside care, a language of the child's quality of life is this, but the child has impacted me in these ways, or has shifted my worldview, or has improved a virtue, grown a virtue in me. And so I'm interested in this concept of, the child brings a quality of life, but then the impact to the family might be celebrated. Next slide. So in visiting with the parents, we specifically asked this cohort, and since this initial cohort, we've actually asked most every family if they might provide guidance for providers. And so in this particular paper, we went through and coded using qualitative software. And I found the guidance from the families to be quite insightful. So that there were 5 main themes, and I would say these themes are quite consistent. Even after the research project stopped, I continue to hear these themes. So number 1 in frequency was to honor the child's intrinsic worth. So guidance to the providers to recognize the child's dignity and purpose and celebrate the relational value in the family. Second most common theme was to offer personalized opportunity. So really a push against universal declarations of, we don't offer this intervention for babies with this genetic condition, but more learn about my pregnancy, my fetus or my baby, and then determine according to their unique needs what fits. Also very strong language of bringing professional courage. So recognize shifts in survival outcomes. Consider that there might be an evolving paradigm of care. Weigh access to interventions with benefits and burdens. So it wasn't about pretending that all children have capacity to receive interventions or to benefit from interventions, but being courageous enough for that child, assess the literature, assess that child's comorbidities, and then determine together. And then a very strong call to foster collaborative communication, recognizing dialogue and approaching language of hearing from the family. So collaborative communication had a strong sub-theme of listening. Next slide. So this paper, we actually just submitted this morning, so it's fresh, but of great interest also as we are exploring the family's experience of quality of life. We're also witnessing providers who, John Lantos from Kansas City coined the phrase, caring in the gray zone or the stable gray zone, where with trisomy 13 or 18, there will be families who transition to comfort care, even immediately from the delivery room. There will be other families who, with the same diagnosis, perhaps the same prognosis, who transition to escalating technology. And so he speaks of a gray zone, whereas in much of medicine, we have a very clear black and white. We do or we do not offer intervention. We do or we do not have benefit. And so he speaks of these conditions as living in the gray. And so I experienced that for families, but then as a palliative consultant, I also experienced that gray zone for providers. And we were curious about, after 3 years of caring for many children with these diagnoses in our setting, the provider perspective and the NICU, specifically whether the discipline, being a bedside nurse or an APP, meaning like a nurse practitioner or physician assistant, or a neonatologist, sort of impacted your perspective. So we did 64, Dr. Nick Torbert, our NICU fellow, interviewed 64 care providers in the NICU and voice recorded those. We had them transcribed and then worked in an interdisciplinary study team to analyze. And what we did experience from staff is that there is a sense of internal conflict that stems much from the stigma, the historic stigma that these diagnoses would not have a good outcome, that had been in historic medical textbooks. There's some conflict with that the person making decisions, so a parent deciding for a child but not having to then bear the physical burden of interventions. There's an emphasis on presentation and prognosis, that there are comorbidities and complexities that are quite variable, grappling with uncertainty that medicine's changing, outcomes are shifting, the family experience, that the family often has prior traumatic experiences with healthcare professionals, and the strong social network, it's often a shared dialogue. But then also a very grounding theme of providing meaningful and cherished care, that is a professional goal. When nurse practitioners shared a life, no matter how many hours and how many months, no matter how many years, to that parent is an eternity. Next slide. So these are the phrases that the frequency of the phrase correlates with the size of the words that most commonly arose during the qualitative interviews with staff. I will share that for the neonatologist MDs and DOs, the most common language was prognosis, comorbidities. That was a strong emphasis for that profession. And then for the bedside nurses, which makes sense when you think of the time at the bedside, the language was quite strongly communicating with families, and then also very strong language of meaningful time and cherished time for families with the baby. So interesting how our professional role impacts the language we might utilize. One of the neonatologists shared a quote, "So when I'm feeling dismal about something, I go back and say, this is an individual who's probably going to be thankful to be in a family, to be supported and to live. If they bring joy to their family and they have a joyful life, then how am I to judge what that means? I am here to build this family and enable them to be as healthy as possible. That is my role." So I am sharing the provider qualitative data concurrently with the family qualitative data because many of the themes were quite consistent. You know, a desire to not cause harm, a desire to foster a meaningful and valued life, and a willingness to explore together what is quality of life. And as families are perceiving high quality of life, what does that look like in a NICU setting, working toward that goal of the child getting home to be with the family. Next slide, please. So those are our references, and we thank you. Thank you for allowing us to share our findings. And most important, thank you to families for trusting us with care and allowing us to learn together.
We thank you, Dr. Weaver and Dr. Burge. And now I am looking, I don't see anybody's hands raised or any questions as of yet. If you do have a question, you can use the feature to either raise your hand and we'll give you access to come on and ask your question yourself, or if you put it in the chat, we will read it for you.
So Kelly, can I make a comment?
Absolutely.
I don't want to take the chair's prerogative, but want to make sure there aren't any other questions. Will the slides be accessible? Someone's asking you, and both of the talks together will be online, Terry, in the next few days, I suspect, on trisomy.org, because I'm going to ask everyone, including my family, to sit down and watch this talk. Nicole, Megan, I'm stirred by your talk. Megan, I have been trying to put a number of things into words qualitatively and also quantify some aspects of my experience of going to soft meetings since 1987. And you've given me new language, and you've also quantified some aspects that it was always hard to exactly figure out how one would measure. I don't want to dominate this part of the conversation because I want people to be able to ask questions, but I have two general comments, and then I want to make sure we still have other questions. One is that we've talked before, Dr. Menon and I, about the notion that's applied in other areas, even of pediatric cardiology, of centers for excellence. So yesterday we talked about that, and I brought this up with the soft board, but I haven't really taken the lead to make something like this happen. But you've given us another stimulus, I think, with Kelly and Terry being on board, for I think soft to take some leadership role, at least nationally, maybe North America, to come up with some sort of criteria, and that there actually be noted centers of excellence. And Dr. Menon proposed, at least in some areas, that's actually helped move care along. And I think, my nomination already, whatever criteria there are, is the Children's of Omaha is already top of my list. The second general comment I wanted to make is maybe a little bit, maybe not so general specific. So I've been in care conferences. I've been in both our PICUs and our NICUs. I've talked to many of my colleagues. I've had many conversations, Nicole, with my neonatal colleagues at all ranges of spectrum. And I think what I hear in somewhat response, Megan, to what you had said is like, oh, the family's already committed to the, I'm not saying this, but they are. The family has already made these commitments. They don't know when to give up. There's times that they need to recognize that there may be times to stop. And the other that I hear, and I hear this from nurses, from NICU, PICU nurses on our Schwartz rounds, and I suspect you're familiar with Schwartz rounds. Anyway, and I also hear this from my colleagues too, that we're the pain and suffering point. That is, we're putting the parents through some pain and suffering, and we're also, look what we're putting the child through. So I'm not necessarily asking you to respond, but these are the most telling discussions I hear at these care conferences, that your work, both your published work, your work under review, and even your language about the meaning, I think provide another perspective for me at least. And I'm still trying to process it and still bringing it into my brain, but my mind and my brain. But anyway, I'll stop at that point. I had some other things I could bring up for Nicole, but I'd rather give other people, rather you have a chance to say a word, Megan, but then want to make sure everybody else has a chance to talk too.
I will start with, I'm sorry.
Go ahead.
I will start with one of the questions in the chat. It said, you alluded to spirituality as a factor for family strengths, but did you actually make any note of what place faith or spirituality played in quality of life scores, or even what part faith plays in which families seek further treatment for their children, either toward or away from surgery?
I love that question. So actually, I'd say probably my top 3 academic interests is actually how spirituality impacts families' decision-making. So I'm so grateful for that question. I actually put as a limitation in our study that spirituality was not discussed. It was not discussed in the provider sense of meaning or purpose. And I was very surprised that spirituality was not discussed in the parental qualitative interviews. Because I define spirituality as what gives you meaning, what gives you purpose, when the world is shaking, what sort of grounds you. So I am inclined to think that it's because we're talking about the deepest meaning that exists for humanity, which is often that of love for our offspring or investment in the next generation. So it was very interesting because like religion wasn't spoken in the interviews. And I also found that so interesting because I experience many of our families do actually come from a certain traditions, whether, and I don't mean always even Christian tradition, but maybe it's Judaism or Islam, where their facet of that is a certain life affirmation. So actually, I've talked to the chaplains about this often because we do witness spiritual transformation in many of our families, their sense of meaning evolving. And we also experience that many times their motivation has a spiritual grounding. So to be honest, I think the next study, so I love that this was a question because it motivates me. I think the next study actually needs to be spiritual evolution in families, and there are validated scales. I also think that would be a beautiful study because my current work has not included bereaved families, and I perceive that as a really, really important voice. So if we explored meaning and evolution of meaning, I perceive we really could welcome bereaved families to that dialogue and learn from existential experiences. So very inclusive spiritual language. So absolutely, I perceive that needs to happen.
Excellent. We have a question from Ashley Pollard. It says, Dr. Weaver, I know that in social media parenting world, there's often talk about your facility as the go-to for information when facilities are unwilling to consider care. Do you have an informational library to help guide new parents with doctors who are unwilling to do the research, helping parents to be stronger advocates with educated information?
Thanks. That's a great question. I don't have informational library. I recognize SOFT does have a strength of gathering parent-oriented information. One thing I did want to be really transparent about is, to me, like to be just very vulnerable and just speak openly, for me as a provider, the greatest success actually is not for families to transfer here for care, to be frank. the greatest success to me is for a family to receive very high quality care in the setting where they are. And that is important because as a palliative provider, I am looking at a baby's anatomy and physiology, comorbidities, but actually I'm really thinking about that baby as a grandbaby, and I'm thinking about the baby as a sibling, as a community member, maybe part of a faith community. And so if the child and family can remain in the context of their community, I personally believe that that is like the best identity for the family. And so I will say, even for families who travel here, I tend to, if I'm following as a consultant, request and even recently require that we have conversations with the pediatrician they've picked at home and the palliative doctor that's closest to them to establish community and conversations and awareness of the child early on. Because my hope, I like the Center of Excellence language. My hope is that every center be a center of excellence, if that makes sense. Like the greatest joy I have is less of a transfer and more of, oh, the setting is willing to offer quality care.
Excellent. And then we have a question from Dr. Glenn Green. He said this was very helpful. Is there any information on changes in meaning over the years for families?
Thanks, Dr. Green, and I deeply admire Dr. Green's work, so I appreciate that language. You know, that's really interesting. I think that might speak to change of meaning. You know, I'm wondering, I think change in meaning of the child's meaning in the family. I think that I'm not able to speak specifically to the trisomy cohort, but there are some longitudinal studies on what we would call the good parent concept, studied by Dr. Pamela Hines, Dr. Chris Buettner, and that has shown us longitudinally, yes, families' perception of the child's meaning and families' perception of their role in the child's life absolutely does change over time, absolutely. And so I think the beauty of all of our work is longitudinal care, because you witness the evolution of meaning.
Dr. Showalter, I've brought you on to speak. I'm going to, if you can unmute yourself so you can ask your question. There you go.
Sure. I'm okay. Hi, this is Scott Showalter, and as John knows, we have a particular interest in shared decision making and these kind of ethical concerns. But my question was, it kind of related to you trying to find ways to help local caregivers, hospitals, in processing all of this. So my question was, did you notice any patterns when the families were rejected surgical intervention? Any patterns that stood out? For instance, were those hospitals less likely to engage in a shared decision-making process, or less likely to depend on ethical conferences when they're trying to make the decisions? Or were the reasons for rejecting the surgical intervention just all over the map?
Very thoughtful. I like maybe a trend that I think we noted was it felt like centers, and this is a little anecdotal, but it felt like centers where there wasn't offering or consideration tended to be providers working a bit autonomously versus an established interdisciplinary team. So it felt like maybe I think an example of this would be a number of patients came to us who already had a trach, already were on a vent, and living in a home. And then the setting said no cardiac intervention. But the child had already been highly medicalized within that setting. The child's quality of life was perceived by the family to be high, and the child was slowly dying of heart failure. And it felt that this was one provider who I would actually say meant well. And I think that's very hard for families to hear. So I'm gentle when I say that. I don't mean, I believe it was a provider who was using data that they were trained with and historic data on outcomes and perceived that they would not want to cause harm. And so my experience was it tended to be a provider working a bit in isolation versus an interdisciplinary team. Because if an ENT and a pulmonologist and a palliative doctor and a caring complex provider were sitting at the table with that provider, they could probably talk through this child's already medicalized. I also noticed a pattern. We collectively noticed a pattern, which is the greatest testimony for centers to change their way is not a paper we write. It's not actually being argumentative or slandering. It's very much that a child goes home and returns to the community and the life is celebrated. That, in candidness, I would say we've witnessed probably 12 centers that initially we received children from who said no intervention. The children went back to their home community, and now we're having active conversations about setting up interdisciplinary care teams. So I perceive that it's a life that speaks and is celebrated much more even than an academic argument or data.
I can just say from the NICU perspective, in talking with referring centers and having communications with the neonatologist, that I've heard similar things to what Dr. Weaver just expressed, is that the referring centers seem to be not working together and having smaller groups working in isolation, where I wonder if everyone had sat down together to come up with a plan of care for the baby, then the trajectory may have been a little bit different. But there also seemed to be multiple episodes where the patient received surgical intervention for a variety of problems, and then one provider drew a line in the sand and said, we're not doing this one particular procedure. And so it seems like the collaboration at the referring center was maybe lacking. And I can imagine how frustrating that would be for a family to undergo so many other interventions and get care for so many other complex issues. But then one person at one point along the journey sort of said, that's it.
Nicole, could I ask you a question? Unless there's another question, Kelly. Is there a question pending?
I don't have any questions pending in the chat or any more hands raised.
So Nicole, thank you for presenting those data to us. That was excellent. The 171 that you mentioned, was that total since 2017, or was that just in 2017? That was total.
Oh, yeah, that's since then. So we broke it down by years, and I'd have to look at that. But it started off with maybe 5 or 10 a year, and then it exploded into like 30 or 40 a year. So that's since that time frame, kind of cumulative.
I was just trying to almost translate that into a numerator over the number of children with trisomy 18 that are born annually in the U.S. So it's still quite small percentage as we might expect, but just wanted to clarify that and just kind of trying to make that.
Some of those were actually with several international consults, so families from outside the U.S. contacting our center as well. So that number includes a handful of babies from outside of the U.S.
I might also add, just as to what Megan said and what you said as well, that in the one child from our institution that was transferred to your children's hospital, just before the transfer, as we were getting records, Dr. Hamill asked for my cell number and called me specifically. I was out of town because he wanted to review that question of how were things going as far as transferring. He wanted the baby to stay at our institution if possible, and I appreciated that. that he had done that. It turned out that our institution was not saying we don't operate on this particular condition. There was our surgeons, given certain factors, including the size of the baby, had one plan as to what they recommended to do. And then when Dr. Hamill reviewed the data, he felt that he could offer total repair. So it was not as much, it certainly wasn't the conflict of we don't operate. It was more a discussion of exactly how we might approach a small baby. So, but I was very, I appreciated that he had talked to one of our cardiologists, and he also talked to me. So, and your both of your messages about we want to create the centers for excellence in every major center in the U.S. So if both of you will take that as a charge with all of us, maybe we'll move forward with that.
Thank you. Thank you. Thank you for having us.
Thank you very much.
Appreciate the opportunity.
Thank you. And I don't have any other questions pending in the chat or anything. So on behalf of the South Board of Directors, again, thank you, Dr. Weaver, and thank you, Dr. Burge, for presenting for us today. You presented some great information, and really, with your passion, really moved us. So we appreciate you taking your time out of your day to do this for us.
Thank you.
Thank you.
Thank you. And we will be having some other events this evening. We have our candle lighting ceremony for our Trisomy Angels happening this evening at 6 o'clock Central Standard Time. And then we also have some more presentations happening tomorrow. So if you head over to trisomy.org, you can check out what we have available for the rest of the week. Thank you, everyone, and we'll be seeing you later.